I have to thank Sebastian Duwe, David Gleicher, and Naomi Woods for supporting me. They are co-authors of our overview paper. I have to thank my Bielefeld colleagues, Katharina Rathmann, Matthias Richter, for being co-authors too. What we did is we screened all the literature available on health inequalities and on strategies to reduce health inequality during recent years. And the result is very ambivalent. We found out the health of the whole population in highly developed countries has been improving for decades. That's a fact. So we do have this improvement, this fundamental improvement. In the European Union, for example, life expectancy increased for all socio-economic groups over the last 40 years for all socio-economic groups. But the gaps in life expectancy between the 27 member states and within these states, between different social groups, have not only persisted, they are, as you have already heard, larger than 20 years ago. The same holds for infant mortality, for death rates, for coronary heart diseases, for stroke, for many cancers, for injury, for self-reported health. There's almost no exception. Only very few diseases are running against this social gradient. Asthma is an example. Some versions of psychiatric diseases. Why does this come? Obviously, in almost all countries, the health of rich people with good education and active participation in the labor force is improving much more quickly than that of the poor with low educational level and weak participation in the labor force. This means increasing economic inequalities have to be observed as the driver of this development, but as we found out, it's not the only driver. You did already hear this. Research is not quite clear about the role of economic inequalities. They seem to be a very important prerequisite, but there's no one-to-one correlation. Some few days ago, there was a new book, was a book released by Richard Wilkinson and Kate Pickett. They called it the spirit level. Why more equal societies almost always do better. In this book, we have complete coverage of all research that has been published during the last 20 or 30 years. And the authors demonstrate with lots of evidence health problems are closely related to income, yes, to wealth inequalities in all highly developed countries and between them. This is true for infant mortality, this is true for life expectancy. So, for example, they have these graphs here. Income inequality, the more you go to the right, the higher is income inequality. Infant deaths per 1,000 live births, the more you go to the top, the higher is the rate of infant deaths. And you find that the United States is in the right upper corner, high degree of income inequality, high degree of infant deaths. Japan and the Scandinavian countries are in the lower left corner, low degree of income inequality, low degree of infant deaths. So we do have this correlation, not so very clear, but still very strong is the regression with life expectancy. The same picture, United States, high income inequality, down in the right corner, with low life expectancy. Japan, Sweden, in the upper corner, with high life expectancy, low income inequality. And the Central European states are in the middle of the picture. They are intermediate in their outcome. Of course, there are some interesting single cases. Singapore is not following these rules, and some other states do not. And Japan is very difficult to explain. How can it be explained? Wilkinson and his team started to deliver explanations. So we found that they have the following hypothesis. The main reason for the development is that highly developed, industrialized states have advanced beyond a crucial stage in economic development, where living standards reach a threshold level, which ensures that the population's basic material needs are met. So they hit somehow a ceiling, and once they have hit it, in the public health, it's the epidemiologic transition, the rules change. No longer only economic inequality now is driving the development, but, and this is the hypothesis, the key role of social inequalities now is beginning. Economic inequality now is transforming into social inequality, and we found out in our class that this has to be the main topic of research. How does this come? What are the rules for this transformation? There's a lot of controversy, of course, about the Wilkinson hypothesis, much going back in discussion, but after all the papers do agree, it is not only income inequality as such which leads to health inequality, but also, and linked to it, the inequality of resources held by different parts of the population due to systematic over and underinvestments across a wide range of community infrastructure. Income inequality is an important manifestation, that means, of a set of historical, political, cultural, economic background factors which create a context of community infrastructure, and we have to grasp this if we want to explain this development. The problem then is, in all highly developed countries, the proportion of the population which does not get a proper share of the profit from the overall improvement of welfare and the overall improvement of health is growing. These parts of the population are relatively disadvantaged, and they are therefore vulnerable, as you can see in the empirical research. Vulnerability is the liability to attack or damage, and this vulnerability obviously depends on the personal, material, and social resources they and their social networks can draw on to cope successfully with potential harm. But this is not a psychological mechanism and not a biological mechanism only. This is embedded in social structure. And here again, we need interdisciplinary explanations and interdisciplinary approaches to grasp this obviously very complicated connection. The quality of life and the economic productivity of the whole country is reduced if significant parts of the population are excluded from welfare resources that are available for the majority. We have to take this as a rule of problems and legitimization problems of welfare societies of all formats. Inequalities are considered to be unfair, and this is a political fact. Therefore, I think effective policy strategies to reduce health inequalities should be part of comprehensive welfare state policy. Now, how can this be done? Obviously, different states have different levels of health of their population, and they also have different levels of health inequality. So research moved into the direction to analyze these differences and find rules and regulations. The analysis of divergent structures of policy strategies seems to be an important tool to learn about the possibilities to influence the determinants of health inequalities. But it is very complicated. It's not really simple to do this and to find the regulations and the rules. Welfare state regimes are an important tool. These regime types are highly significant predictors of health indicators. Research literature is showing. They are influenced by the traditional path. There are significant 3 or 4 or 5 types. Espinal will talk about it, and Claire Baumhar will talk about it. There are traditional paths to organize the societal infrastructure, and these welfare regimes influence the quality of welfare of the whole population. Obviously, shared policy characteristics of a given welfare regime do exist. We do have the typology of S.P. Andersen. He was the first, and he is the most prominent author in this field. He distinguished 3 types of welfare states, a very convincing model, I think, and we found in our class that the critical discussion of this typology did not really lead to very strong alternatives. So he distinguishes the liberal type with the dominance of market. He spells out the conservative type. Germany, France are examples from this type, with they focus on civil networks. He calls the third type the social democratic welfare state type regime, with a focus on state. They are different in terms of the degree of egalitarianism in civil and human rights, in the degree of universalism in provision of social services for citizens, in terms of generosity of social security arrangements for unemployment, sickness, old age. So all this works out fine, and you can identify 3 ideal types of welfare state policy with path-dependent regime backgrounds. What do they explain? Espinal and the other researchers will give more details about it, but we found that the general result of this research is that typologies are able to explain the relatively high degree of social and economic inequalities in most of the social democratic regimes. So they are relatively equal in terms of economics, in terms of social, in terms of health, but not in a one-to-one relation again. Contrary to expectation, they are not able, these welfare state typologies, then to explain why the social democratic regime, which is best in reducing economic and social, mainly economic social inequality, and is very successful in establishing at least a notion of equality. Why does this regime not turn out to have the healthiest population? In some of the comparative research, it's the conservative regimes that are better. The liberal regimes never are best, but we did not find out what the difference between the 2 winners in this comparison could be, the social democratic welfare regime and the conservative welfare regime. We think that this is not satisfying, and we tried to gather the critique and to search for alternative explanations. So the critique is that the approaches only include distal variables on a high level of aggregation. Welfare state regimes are very ideal type format, and they are very far from the detailed structure of the single countries. So it's distal variables, methodologically speaking, high level of aggregation. Second, they omit the translation of policy strategies into politics. There is no interaction of policy strategies and political activities. As a result, they do not differentiate between public health and general health policies. And most of the typologies do not separate structural causal variables from interaction variables. So we did find an interesting explanatory model from the Navarro team, which you can see here. The Navarro team stresses politics as the dependent variable. They are calculating and researching time in government by different political traditions, electoral support for different political traditions, measured by power resources, supporting each political tradition. So this turns out to be a very important empirical determinants. They introduce labor market policy, they introduce welfare state policy and politics, and try by this to show that policy regime types and their politics have to be put into correlation. They consider economic inequality, however, as being the only important linkage to health outcomes. So this then was our critique. First, there is no separation of structural determinants and political intervention. This model, we think, is too political. It stresses the political intervention and politics activities too much and forgets about the path dependency of political activity. And second, it sticks too directly to the transformation or the translation of economic inequality into health inequality. But the research, as I have reported, does not support this direct connection. There is no direct connection between health inequality and between economic inequality and health inequality. So we dared to develop a known model and tried to take care of these critical points. Our dependent variable is the organization of the societal infrastructure. Here we put in all the welfare state regime elements. This is the box for the welfare state infrastructure, usually established since centuries, or at least since decades. So it is a very powerful variable, and we do think this has to be taken into consideration as the starting point of every explanation of inequalities whatsoever. Second, we define this box quality of population welfare. Here we put in the degree of economic equality or inequality by income and by wealth. Employment, the degree of employment for all age groups, the degree of relative poverty, working conditions, participation of women in the labor force, education, occupational training. So this is the social fabric of the welfare state, so to say, political participation, trust in governmental agency, reliance on police and legal system, cultural integration of migrants. All this is in our box quality of population welfare. Criminality, sense of control, availability for good food and water, shelter from environmental contamination. And our thinking is that the economic inequality is linked within the box quality of population welfare already with these more social determinants and social parameters of importance for the quality of the population welfare. These two variables do influence health status, the health status of the population, and the health inequality that you find in the population. These are the more structural variables in our thinking, and then we distinguish the more political variables. We can discuss about the direction of the arrow from the organization of the societal infrastructure to public policy. We can hope that there is an arrow going back from public policy to the organization of the societal infrastructure, but that's a matter of discussion. As a rule, I would say the organization of the societal infrastructure is so powerful and so determined that by simple public policy you do not really touch it. This is the reason for the direction of this arrow. And we put into the box public policy, which we have called health-sensitive public policy. First, public policy in areas such as agriculture, labor, energy, environment, economy, social security, trade, foreign policy, immigration, education, all the classical fields of policy, public policy. The quality of intersectoral coordination, which turns out to be very important in this area here, and the intensity of public health and healthcare policy, expressed, for example, by the expenditure for public health provisions, expenditure for healthcare services, evaluation of the quality of healthcare services, and so on. So we think it has to be expressed the political power of public health and healthcare policy in government and civil society. And this decides whether it is a high or a low degree of health sensitivity of public policy that we can observe. The more health-sensitive public policy is, the higher is the power to directly influence health status of the population and health inequality. This is our idea for this more complex explanatory model. This model then follows the assumption that the welfare state regime types do set the stage for the architecture of public policy. The degree of health sensitivity of this public policy then influences the health outcome via two paths, as you have seen. First, indirectly by determining the overall welfare of the population, and second, directly by shaping the institutions and organizations which are responsible for healthcare. In using this term that we have phrased, health-sensitive public policy, we definitely invoke the wider European notion of social policy, which includes not only healthcare, but, as you have seen, labor policy, social security, social housing, criminal justice, education policy, unemployment insurance, as constitutional elements of welfare policy. And this approach then seeks to define policy fields outside of health, which in addition to their existing purposes can be seen as tools to improve population health status and reduce health inequalities. Our literature review found that this is extremely important. So whenever we want to reduce health inequalities, we do not have to focus in an isolated manner on health policy, but we have to open the picture and introduce public policy as a general topic. This model gives the answer to the question, why does the economic inequality not directly transform into health inequality? We think because health inequality is influenced by this combination of economic inequality and social and cultural inequality on the more structural level, and is influenced by the make-up and the architecture of general public policy and health policy in specific. Health-sensitive public policy finally recognizes that welfare and health policy follow strong path dependencies. Therefore, states with different welfare traditions need specific strategies to reduce health inequalities. This is our main result and conclusion. The states with the tradition of different welfare state models and types do have to apply different policy strategies. I think it's very important for international organizations, very important for the transformation of political activities into national policy. It doesn't help just to try to copy elements from a strange welfare type system. You do have to invent elements that fit your system, fit your policy tradition. This means, so in the case of Germany, for example, with our more conservative Bismarckian welfare system, adding public health and prevention turns out to be extremely difficult because it's tax-financed, and we do not have a tax-based system for supporting and providing healthcare. And our system has to deal with this problem. We will have 2 case studies after Espen Dahl now will give his presentation. One case study is the United States, and Rick Brown will give us an impression of the difficulty to change public policy and health policy in specific in order to achieve at least something like universal coverage of the population. And I think the path dependency here, again, is very important. And we will have the other extreme case, Finland, and Seppo Koskinen will give us a picture of this, of the architecture of health policy and public policy in this country, and draw his conclusions. So this is the idea for the next 2 presentations of this conference. And first of all, it's a pleasure for me to ask Espen Dahl from Oslo University, from Research Center, to give his presentation. And I know that you do have some quite new and innovative research results that we hear for the first time. Thank you for coming. And thank you.